So thank you for the opportunity to present today. My name is Alison Marshall, as mentioned. I'm doing a PhD at the University of New South Wales, and I'm also a trainee in the CAN-Hep-C program. So today I'm going to be presenting a review of restrictions for reimbursement of second-generation HCV DAAs in Canada. As Jason mentioned, I also wanted to thank all the study authors involved for their expertise and guidance. And I'd particularly like to thank Sahar for all the work that she did on this submitted paper as well. So as discussed earlier today, second-generation HCV DAAs have high cure rates, minimal adverse events, and shorter treatment duration. And so with this, it is anticipated that they'll have increased treatment uptake among patients. However, as discussed many times today, the list price in Canada is highly prohibitive for these drugs, about $60,000 for a 12-week course of ledipivir/sivosavir. So universal drug coverage for the approximately 252,000 people in Canada that are living with hepatitis C presents immense challenges. So part of the reason why we wanted to look at Canadian reimbursement criteria is that there was a previous study that looked at sivosavir reimbursement criteria in the US. So of 42 US states with available Medicaid data, the majority requested evidence of advanced fibrosis, so F3 or higher. The vast majority had drug or alcohol use restrictions. Nearly a quarter required HIV co-infected to be treated with ART or to have suppressed HIV viral loads, and a sizable number limited prescriber type to specialists only. So as we have discussed today, these restrictions are not, they do not align with American, Canadian, or European guidelines. So to show visually, this is the fibrosis stage restrictions in the US, and as we can see, most of it is the medium color blue represented by the F3. But there's also a few states in there that even have F4, so a requirement of cirrhosis to be eligible for treatment. So Oregon on the far west coast there, and Illinois. Similarly, the vast majority had drug or alcohol use restrictions. So an individual would have to abstain from alcohol or drug use for a certain length of time to be eligible for treatment. And again, Illinois is following a very strict pattern, so they're requiring abstinence for up to 12 months prior to receiving treatment. And also, it's important to note that in some cases, this includes someone not being able to be on opiate substitution treatment at the same time as receiving treatment. Canada, as many of you know, is different than the US in that Canada has a pharmaceutical alliance. So any review that's been completed by the Common Drug Review or the Pan-Canadian Oncology Drug Review are considered to go into negotiations with a drug manufacturer to discuss pricing agreement. For brand name drugs, this is being led by Ontario. Now, what should be noted is that ultimately the health ministry in each province or territory sets its own reimbursement criteria, and it should also be noted that it is possible for a jurisdiction to completely bypass the pharmaceutical alliance and negotiate with a drug manufacturer directly. So it would still be possible to have heterogeneity across Canada in terms of reimbursement criteria. So the aims of this review was to look at the reimbursement criteria in Canada for these 4 therapies. And we were also interested at looking at criteria for First Nations people and Inuit, and also federal prisoners, as these populations are disproportionately affected by hepatitis C in Canada, and also because they fall under a federal plan. Our hypothesis was that Canada would have more consistent criteria across jurisdictions compared to the US, partly as a result of the existence of the Pharmaceutical Alliance. So our primary outcomes of interest were looking at the minimum fibrosis stage required. Are there drug and alcohol use restrictions? If yes, what are they? HIV co-infection restrictions, and also prescriber type restrictions. So data or information was collected over a 9-month period, primarily from health ministry websites, so sifting through special authorization request forms and drug formularies. 2 authors collected the data, cross-checked the data, and any inconsistencies were resolved through consensus. With analysis, descriptive statistics were used to look at the proportion of province territories that restrict drug coverage by the outcome of interest. So when pooling all these 4 therapies together, it was found that the vast majority of provinces and territories limit access to persons to moderate fibrosis, so F2 or higher. That's in contrast to the US, being F3. There are no drug and alcohol use restrictions listed. However, there were cases of a restriction that could be listed and then in brackets at the discretion of the physician. So for example, in PEI, it might say active injecting drug user is in the exclusion criteria, and then in brackets, it'll say at the discretion of the physician. Quebec does not reimburse Zemepivir or Sofosbuvir for HIV co-infected persons, and no restrictions were found in the remaining jurisdictions. However, I have been told by people based in Quebec that there is a possibility to go a patient exception route, so you would still be able to get those medications for HIV co-infected persons. Up to half of jurisdictions restrict prescriber type to specialist prescribing only. However, when you start looking at the medications that do not involve PEG interferon, you can see that there's more opportunities for GPs with experience to prescribe. Now, the Aboriginal and the federal prisoner criteria was similar to the other jurisdictions, except that the federal prisoner criteria, even though it says F2 on there, there's an explicit statement that there's priority for F3 and F4 patients, and also that directly observed therapy is required. And with the Aboriginal criteria, there's an explicit statement there as well that's notable, and that does this patient have access to a multidisciplinary support team? So looking at this visually, when looking at minimum fibrosis stage by the 4 different therapies, we can see that Quebec is a special case. With Zemepivir and Sofosbuvir, Quebec is in pink because we actually couldn't find any information listed specifically to say what the fibrosis stage requirement was. However, when speaking again with people in Quebec, they're saying, well, that's because there isn't actually a restriction for those, fibrosis stage restriction for those 2 medications. However, with the later 2 medications, we can see Quebec is in a darker blue because at this point in time, a patient would need to have F3 or higher. But Quebec is implementing a staged sort of system where in 2016 to 2017, it'll go down to F2. And then the following year, it'll go down to F1. And then by year 4 and 6 that the medications have been on the market, there will be no restrictions for patients. And as you can see as well, PEI has no restrictions for the medication that they reimburse. So into final points here is that, yes, there was less HCV-DAA heterogeneity by jurisdiction in Canada than the US. However, Canada is quite similar to a lot of other countries in that they require a minimum fibrosis stage. The recent American guidelines suggest not prioritizing by disease stage, and also a recent CADTH review so that treatment across all disease stages is cost effective. So it might be worth the jurisdictions in Canada re-reviewing that restriction. Also, I think a national hepatitis C strategy in Canada would be helpful to reduce any sort of heterogeneity by jurisdiction, and I think it would help to improve information transparency. Certainly limitations, access to information was challenging. It was all online. Each jurisdiction lists the information in a different area, different forms. The study or review cannot speak to implementation. What's being listed might not be what's happening in practice. And also additional research might show greater heterogeneity across jurisdictions. So for example, if we had looked into the methods by which fibrosis staging was occurring, if we were looking at fibrosis value cutoff points, we might see greater heterogeneity by jurisdiction. And also additional research that looked at private health insurance criteria would have been interesting, but unfortunately we were unable to access that information. And because the next discussion is looking at research into policy, I thought I'd provide a quick snapshot of what's happening in Australia right now. So on March 1st, the pharmaceutical benefits listing is going to include ledipasvir, sofosbuvir, and decladisvir. This is a national program, so each state and territory will follow the same criteria. There's no disease stage restriction. There's no alcohol or drug restrictions. It looks like GPs will be able to prescribe in consultation with a specialist. That will include, for example, an email or a phone call. Retreatment looks like it's going to be possible. The co-payment is minimal for patients, the $6, the concessional amount. And also it looks like that the GP is just going to have to write a prescription. So the administrative burden is quite low. And also it's important to note that Australia has about 230,000 people that are chronically infected with hepatitis C out of a population of 23 million. So if Australia was, if we used the same colors and the same primary outcomes to look at what Australia's map would look like, it would all be the same color and pale blue because there are no restrictions for the outcomes that we looked at for Canada and the US. And finally, I just wanted to also thank again the study authors, my supervisors, the Ministries of Health, and I'm very grateful for my student scholarships. Thank you.
Just one quick question. Did you look at what type of formulary or access procedure? I twigged to that because you said in Australia it's on the general formulary, for want of a better term. But my understanding in Canada is Holkirapac, Harvoni, and the subsequent ones will be on exceptional access, special access, and other like programs which have put a high administrative burden on the healthcare team in terms of application.
Right. So there was certainly a discussion within the group about being able to perhaps measure administrative burden because this was something that came up a lot among the clinicians of the group in particular. And we weren't able to develop a way to do that that made sense. But certainly when the data collection took place by going through all of those forms that you're referring to.
And I appreciate that you weren't able to look at implementation, but just to add a little caveat to the CSC, the Correctional Services has a hard cap on the number of people they will treat. So the criteria go out the window after 240 people have been treated. Right. And that will increase to 290, we expect, in this coming fiscal year. And that's been documented in CMAJ in the news section by Paul Webster in a series of articles.
Right.
Thank you.
Thank you.